time it is. Marvin Devine, Hoover, Axel, and you know how we do. Yeah, I got the juice. Whip game cool, make them look like cool. Always play cool, that's the biggest rule. Fuck it, what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, Axel, and Hoover, way too fireable. When this joint drop, that is called the truth. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we link up. Let's go. Yeah, I got.
Hello and welcome to Kidney Hub East Africa, your trusted platform for kidney health education, awareness, and inspiration. I am your host, Steve, the Kidney Nurse, and I'm so glad that you could join us today for another very important conversation about kidney health. What's going on, everybody? It's been another week. If you're watching this right now, share this live. If you're in East Africa, hello Kenya, hello Ethiopia, hello Zambia. Share this live right now. We have a very important topic we're going to talk about, and we're honored for a special guest, Dr. Khalida Soki. So today's topic is early detection of kidney disease. Now, this is a topic that affects families, communities, and health systems across East Africa and around the world. We are broadcasting live on Steve the Kidney Nurse YouTube channel, Steve the Kidney Nurse Facebook page, and the Figo Initiative Facebook page. Please feel free to share this live broadcast with your family and friends. We definitely appreciate it. I'm honored to be joined by my amazing co-host, Moses Kennedy, also known as the Kidney Ambassador, and renal nurse specialist, Tabitha Matikwa. Today, man, this is going to be a great show. Today, we are honored to be joined by Dr. Khalida B. Soki, a senior consultant transplant nephrologist with extensive experience in advanced kidney care and transplantation. Dr. Soki practiced at the Nairobi Hospital under Kidney Care Consultants and served as medical director of Figo Care Plus Dialysis Centers. She is also chair of the Transplant Committee at the Kenya Renal Association. And this is crazy. I mean, it's not crazy, but this doctor has an impressive background, Deputy Secretary General of the African Association of Nephrology. So sit back, stay tuned, let's learn, share, and grow together on Kidney Hub East Africa. Before we bring out our co-host and guests, let me go over, as we do each week, our medical disclaimer. Now, let me bring it up. Kidney Hub East Africa. The information broadcast on Kidney Hub East Africa is provided for educational and informational purposes only, and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. So with that out the way, let me bring on our co-host all the way. We got one from Nairobi, Kenya, and one from Kisumu, Kenya. Brother Moses Kennedy and Sister Tabitha Matikwa. Hey, let me get this right. Okay, there we go. Hey, Tabitha, how you doing? Brother Moses, welcome to the show. Again, thank you for coming back again, as always. What's going on?
Thank you so much, Brother Steve. I'm honored to be here and absolutely super excited for this important discussion. Thank you so much.
Yeah, it's always good to see you, Brother Moses. You know, we've been doing this for like 4 or 5 years. I can't, pinpoint. I know you probably know, but we've been doing this kind of consistently. We've taken hiatus, but we always come back to try to get that information out there. And you pretty much been the spearhead of this because of what you experienced in Kenya as a dialysis warrior. So, man, thank you so much. I truly am honored to be your friend and to do these shows consistently on Sunday. So thank you for showing up. Even sometime when you don't feel well, you still show up. So that's dedication right there.
Thank you so much.
Yeah. Hey, Tabitha, how's it going?
I'm fine. I had a very great week and also a great Sunday. I'm honored to be in this conversation today on early detection, and I'm really excited about it today. Thank you.
Yeah, and Tabitha, I just wanted to tell you as well, thank you for coming on, taking time out from your family and your responsibilities to spend this short time with us to share your knowledge and experience and to add value to the conversation, because I know life for everyone be life and we all have our lives and responsibilities, but for you to join us each week now in the conversation, I really appreciate your time and dedication. So thank you so much.
Thank you.
Yeah.
Thank you, brother.
Absolutely. So let me share, for people just joining us, we're going to be talking to Dr. Soki, who's a nephrologist in Kenya. But let me share Dr. Soki's impressive background and experience. She's senior consultant transplant nephrologist. Dr. Khalida B. Soki is a distinguished senior consultant transplant nephrologist with extensive expertise in advanced kidney care and renal transplantation. She practices at the Nairobi Hospital under kidney care consultants, where she provides comprehensive care across the full spectrum of kidney disease with a particular focus on kidney transplantation and long-term renal outcomes. Dr. Soki holds a bachelor's of medicine and bachelor's of surgery and the master's, wow, of medicine and internal medicine, and has undertaken advanced subspecialty training in transplant nephrology in Alberta, Canada. She also she is also a fellow of the International Society of Nephrology, reflecting her global recognition and commitment to excellence and nephrology practice. She also serves as the medical director of Figo Care plus Dialysis Centers, where she oversees the delivery of high quality dialysis services and drives clinical standards in renal replacement therapy. In addition, she plays a key leadership role as chair of the Transplant Committee and the Kenya Renal Association, contributing to the advancement of transplant policy, practice, and capacity in Kenya. At the continental level, Dr. Soki serves as Deputy Secretary General of the African Association of Nephrology, where she is actively involved in shaping nephrology practice, education, and collaboration across Africa. Dr. Soki is widely recognized for her leadership in transplant medicine, including patient selection, peri-transplant optimization, and post-transplant care. Excuse me. She is also deeply committed to expanding access to kidney transplantation, improving patient outcomes, and strengthening multidisciplinary approaches to kidney care. Her clinical approach combines evidence-based practice, innovation, and compassionate care, ensuring patients receive holistic and personalized treatment throughout their kidney care journey. I mean, that's very impressive. And I have questions that I want to ask Dr. Soki about this whole transplant, because the way Brother Moses says and Sister Tabitha, you have to be a relative in order to to give a kidney to someone like your family member. You got to be a relative. If you're not a relative, you can't be an altruistic donor. So we want to know, is that going to ever change in Kenya, where if anyone wanted to donate out of altruistic measures, not from financial, because we know there's always going to be that space of black marketing where people are going to want to benefit off of selling their organs. But we're going to find out if there's anything in the works that is going to be able to have a regular Kenyan citizen or East African citizen be able to donate. So without further ado, let's welcome our wonderful guest, Dr. Soki, to Kidney Hub East Africa. Let me give her the VIP welcome. Dr. Soki, welcome to Kidney Hub East Africa. We are truly honored to have you with us today. Welcome.
Thank you. Thank you so much. It's such an honor to be here and to be invited onto the show. Thank you, Moses, for reaching out, and lovely to meet you, Steve. And Tabitha has known me for many, many years. So just wonderful to be on the show. Thank you.
Wow, that's amazing that this comes full circle that that Tabitha has known you for many years.
I think Tabitha has taught me.
Really?
And that is a testament to her experience and her knowledge, and so it really is an honor to be on this platform with her.
Wow, we're honored and grateful to have you here today, because we know that nephrologists, no matter where you're at in the United States, East Africa, that you're very busy taking care of kidney patients. Dr. Soki, to begin, when we talk about early detection of kidney disease, what does that really mean for the average person in Kenya?
So it is a shame that in Kenya we do end up making diagnosis of kidney disease quite late. In fact, one of the things that we emphasize to our patients and to the medical fraternity and to the public in general is that we as nephrologists are not dialysis doctors, because that's usually when patients end up with us when it's time for dialysis. We are not dialysis doctors. We are doctors who prevent dialysis. We conserve kidney function, and that is possible if we were able to detect kidney disease early. So we do not have any official screening programs in Kenya, and that's really something that we do need to work on. And yet we know that in Kenya, as far as we know, the prevalence of kidney disease is about 9.7% in Kenya, and that means that 1 in 10 people in Kenya has chronic kidney disease, and most of them don't know that. So definitely a need for screening services and screening programs in Kenya for kidney disease, which are currently not available. So, yeah.
All right. Brother Moses, let me just ask one more question, follow before you ask your question. Dr. Soki, I was on live last night on TikTok, and there's a nephrologist on TikTok named Dr. Chidima. I don't know her full name, but she's from Nigeria. And she mentioned that in Nigeria, the system there is pay out of your pocket to get service. So if you don't have any money, you don't get dialysis. Is that, I know in Kenya, Brother Moses told me it's the NIH or NIS. I'm not exactly sure about the insurance name, but is that almost the same case with patients in Kenya? Maybe they get dialysis, pay for dialysis, but any extra services like medicines like iron medicines or medicines like phosphorus binders, they got to come out of their pocket for that, like Epogen, ESAs. Is that the case there in Kenya?
So, firstly, so we used to have the NHIF, which has become the Social Health Authority, SHA, right now. And we're very grateful, to be honest, because Kenya was one of the countries that pioneered, one of the African countries that pioneered taking over the cost of dialysis. But it was at a point in 2015, 2016, when the government did not actually know the prevalence of kidney disease in Kenya. And so were really underprepared to take on the cost of renal replacement therapy, which, as we all know, is a major contributor to the health budgets worldwide. I mean, looking at the countries that have bigger GDPs, the global north, we do know that a large chunk of the health budget is actually allocated to renal replacement therapy and dialysis services. So our country was not prepared for what happened thereafter. So what SHA did, or NHIF did, and now SHA does, is that SHA will pay for 2 hemodialysis sessions in a week for patients in end-stage kidney disease. So there is no criteria for who qualifies for this, which to some extent we are grateful for, because it means that there's no exclusion. But it means that our patients are chronically under-dialyzed. As you are aware, everywhere around the world, the gold standard is 3 times a week dialysis, but our patients only get 2 times a week dialysis. So, and that is hemodialysis. They do not have the option of home hemodialysis. They do not have the option of peritoneal dialysis. So our patients are chronically under-dialyzed. They chronically have high potassium levels, high phosphate levels. They have severe bone and mineral bone disease. And the government will pay for hemodialysis, but only recently have they started paying for the creation of fistulas, and that is only in very specific centers. I'm not aware of anywhere that they actually pay for the fixation or exchange of hemodialysis catheters, except Kenyatta National Hospital, which is the level 5 referral hospital level, the highest level of referral hospital in the country. And even then, patients have to pay for their catheter. So it really is out of reach for many people. A lot of their costs come out of pocket, as Moses will attest, the cost of antihypertensives, of phosphate binders. There are no nutritional supplements that are provided, and so patients have to pay for that out of their pocket. So many patients actually do find themselves in a very tough position. And as nephrologists in Kenya, we have learned to deal with complications that no other nephrology service has ever been able to teach me about, not my nephrology training in the UK and not my transplant training in Canada, because we deal with very high potassium levels, very high phosphate levels, patients who are malnourished because of doing 2 times a week dialysis. These are very big challenges on our patient population, and they really are very brave and very wonderful people.
Mm-hmm. Brother Moses, let me just ask one more question. I'm sorry. It's just on my heart. I talked about it last night with another nephrologist. And Doc, you know, I do advocacy on social media. Like I mentioned to you before the show, I've been involved in dialysis for nearly 41 years.
That's amazing.
When you hear or you see the issues going on in Gaza, where kidney disease is all across the world, and you have patients who were going to dialysis 3 times a week before the war started, and now you have patients subjected to 1 day a week, 2 hours treatment because of infrastructure, no power, lack of water for the machines, lack of supplies coming in. Do that bother you as a nephrologist, or have you seen that, or that's happening in Gaza with that situation? And if you have, as a nephrologist, does that bother you?
So who would say no, you know? It's heartbreaking. It's devastating. I know also closer to home, we had the same situation in Sudan, which was very difficult. And we see this in our patients. I know we went through something not similar, of course, not your entire country and your entire home being demolished, and then you have a medical emergency to deal with. Not that, but we went through something like that for our dialysis patients when it was COVID time, and our patients would come in, and many of them have a cough because of pulmonary edema, because they're only receiving dialysis twice a week. And that means they have water in their lungs. And our patients would come in coughing, and then their dialysis unit would refuse to dialyze them. Or we would have a situation where one of our patients would turn positive for COVID, and then nobody would accept them for dialysis. And then this also happened in 2023 in Sudan when the civil war broke out in Sudan. And I remember one of the nephrologists had a parent who was on dialysis and now suddenly couldn't receive dialysis because of the war. And their parent actually ended up passing away because they couldn't access dialysis. There was no water, there were no consumables. And now you look at the situation in Gaza, and it really is, for people who were stable and people who had services and medical services available to them, having their infrastructure gone, their water gone, their consumables gone, their doctors gone, their health facilities gone. It really is just a heartbreaking situation. Yeah.
Thank you for answering that, Doc. All right, Brother Moses.
Oh, thank you so much. Dr. Soki, people often hear that kidney disease is a silent condition. Why is it so easy for someone to have kidney damage and not know it?
That is just a wonderful question, Moses. So the thing to remember about kidney disease is that I like to remind people that most of us are born with 100% kidney function. But for us to be completely normal, all we ever needed was about 20% kidney function. And that's because 80% of our kidney function is actually reserve. It's backup, right? But it's backup that's supposed to last us our whole lives. So what happens is that when people have kidney disease, their filters are breaking down or getting damaged one by one. And you have a lot of filters. You have about 3 million filters, and that's why it also takes time. So what happens is that kidney disease usually does not have pain. So what happens is that we're getting damaged to the filters one by one, and you have this 80% buffer. And if you were not checking, then what usually happens is people end up coming into us when they start feeling unwell and getting the symptoms of not having enough filters. And this is usually when their kidney function has fallen below 20%. For many people, when their kidney function has fallen below 10%. And this is why we have to advocate for early screening. Kidney disease does not have pain. Most people are waiting to feel some sort of pain. They're thinking about kidney stones. They're thinking about an infection. But for most kidney diseases do not have pain. And we are silently losing our filters in our kidneys. And by the time we're getting any symptoms, it is because we usually have less than 20%, maybe even less than 10% kidney function. So this is why we need to screen and look for the people who actually are suffering from kidney disease. So you might have 100% kidney function, you have no symptoms. 80% kidney function, you have no symptoms. 50% kidney function, you have no symptoms. 30% kidney function, you have no symptoms. Even 20% kidney function, you might not have any symptoms. So, and the thing about kidney disease is, what I'm telling you is you only needed about 20% kidney function to be completely normal. That means if we find people at 50%, at 30%, at 60%, 40%, we can stop the damage to the filters and conserve their kidney function so that they never end up on dialysis. So finding those people early, getting them on treatment, and saving their kidney function is of paramount importance.
Dr. Soki, let me ask you, you said that people could go down to 30% and not have any symptoms. Now, let's say if someone has stage 4 kidney disease and they experience like tiredness, some metallic taste in their mouth, or other symptoms. Can some symptoms of kidney disease mimic other conditions that can maybe prevent somebody from going to get it checked out because they may think it's the flu or common cold or something like that?
I think absolutely that is what happens with most people. That with most people, you'll attribute it to, oh, I'm feeling a little bit tired and I've been overworking. That's what many people will tell me. I thought I was overworking. I thought I had a flu. I thought, And so many people won't get checked out. I remember one patient telling me, I was feeling weak and I was like, I've not gone to the gym for a while. I've not been exercising and I've been really stressed at work and I'm not sleeping and I'm really stressed at work. And so many of the symptoms of kidney disease are actually attributable to just life, and especially when this happens in young people. And in Kenya, especially, and I think in most of East Africa, half of our people who are on dialysis are very young. They're between the ages of 18 to 32.
Wow.
When they're diagnosed, half. So it's not your typical older person who has diabetes and, has heart disease. And so many of them will attribute it to something going on in their life. They're in their 30s, they have their kids, they're busy at work and will not go and get checked.
Wow.
Yeah.
All right, Brother Moses, you got a follow-up?
Back to you, Tabitha.
We can't hear you, Tabitha.
Oh, thank you so much, Dr. Soki, for being with us in this forum. And from a nursing point of view, we often see patients come very late, and maybe you can highlight some of the early signs or changes that people should never ignore.
Yeah, definitely. So there's the non-specific signs and symptoms, but some things you should never ignore. Number one, if you do have pain in your flanks right there, that could be kidney pain, and go and check it out. But that one does not happen very often. But if you do have pain, go get it checked out. The second thing is that if you have swelling of your legs, so many people will assume, I stand around for a long time. But if you have swelling of your legs, that's probably a sign you need to get your kidneys checked out. If you ever go somewhere and somebody says you have low blood levels, or somebody makes a comment that you look like, sometimes you'll have a medic looking at you and saying, oh, you look like you have low blood levels. They check your palms, they check your eyes, and they say, check your blood levels and it's low. That's probably a good sign to get your kidney function checked. Many times, if you have pain when you urinate, a pain of any sort should make you go and get things checked. But a lot of people leak out protein in their urine when they have kidney disease or blood. So if you ever notice blood in your urine, you need to go and get that checked. But for many people, when they pee, people should look at their urine. So when they pee, you see this really frothy or foamy urine. In Kiswahili, we call it povu. It looks like you have soap or bubbles in your urine, and that's not normal. And you should go and get that checked. So swollen legs, foamy urine, blood in urine, having low blood levels, these are, or any person who has high blood pressure. If your pressure is high blood pressure can cause kidney disease. But the first sign usually of kidney disease, especially in a young person, is high blood pressure. I find people who at the age of 18, at the age of 15, at the age of 22, were told your blood pressure is high, you should have that looked at. Those people have kidney disease. More often than not, that was the beginning of the kidney disease. And they were told at a young age they have high blood pressure. And that was the first sign that they have kidney disease. If anybody tells you at any point in your life that you have high blood pressure, your kidney needs to be checked.
Thank you so much, Dr. Soki. I remember many times when you're doing screening for donors, we get so many patients with the high blood pressure, and mostly it's good for people to know that your pressure can be very high and you're not even feeling anything. Yep. And therefore, you record several times your blood. If you do several records of high blood pressure, you need to get checked by your doctor, or you need an advice from a specialist. Thank you so much. I would like to hand over to Brother Steve.
Dr. Soki, so for viewers who may be watching this right now or be watching this in the future, who feel completely fine, what would you say to encourage them not to wait for symptoms before getting checked?
So there are certain people who are predisposed to kidney disease, and they should get screened. Because the thing about kidney disease, most people think, so what are you going to do about it? There's nothing that you can do about it. There's no point in knowing about it. It's going to cause me anxiety, and there's nothing that you can do. Kidney disease is treatable. Chronic kidney disease is not kidney failure. What we define as chronic kidney disease is a kidney function above 15%, okay? And any kidney function that is above 15% can be preserved so that we don't end up on dialysis. Dialysis, we end up on dialysis usually when our kidney function falls below 10%. So if you present to us as kidney doctors with your kidney function anywhere above that, we can try and treat the problem and conserve our filters so that we don't end up on dialysis. Even if we do eventually end up on dialysis, finding the kidney disease earlier makes sure that we can prolong the time until dialysis. And these days, we have many, many medications that can treat the kidney disease or prolong the time until dialysis. So I have many patients who I follow up in my clinic. Actually, majority of our patients are patients who have 20% kidney function, 30% kidney function, 40, 50% kidney function, who have blood and protein in their urine. And these are patients who, this is our work to make sure that these patients never end up in kidney failure. They have chronic kidney disease. They do not have kidney failure. These people are walking around and living normal lives on a normal diet, on traveling, working, and we make sure that they don't end up in kidney failure. So it is of paramount importance to find our chronic kidney disease patients early and start them on treatment so that they never end up on kidney failure.
Brother Moses, let me just ask one question that came to mind that I just want to get Dr. Soki's opinion on, because this is something that really impacts not just people in East Africa, but here in the United States and around the world. Dr. Soki, just quick, brief discussion on the use of supplements. Is that a big problem in Kenya when it comes to acute kidney injury? Like you see online, like these products that say it's going to help flush the kidneys or stop kidney failure, the progression, or reverse the symptoms. Do you see a lot of that in Kenya, especially with like the practice of traditional medicines to address kidney failure? Is that a big issue there?
It's a very big issue in Kenya. I can name 4 of my patients off the top of my head. I will sometimes blame us as medics for making things maybe complicated or unreachable or ununderstandable for our patients. And we need to work on advocacy and education. But it is a major problem that we have. First things first, we have a problem of the use of herbal supplements for the treatment of basically everything. So as for the treatment of arthritis, for the treatment of skin diseases, for contraception, and a lot of these actually cause acute kidney injury and failure and acute liver injury and failure. So these are problems that we deal with. The use of traditional or herbal supplements. And for a lot of people, they don't actually know what is in this treatments, and they're harmful to them. So Tabitha will tell you, maybe, I don't know if Tabitha, you remember there was an outbreak about, now it's about 14, 13 years ago at Kenyatta, where a lot of people were getting some herbal treatments, and we had a lot of kidney injury and liver injury in the medical wards. So as a cause of kidney injury, we have a lot of herbal supplements, but also use of over-the-counter medications. So buying medications over the counter in Kenya is unregulated. So a lot of people take non-steroidal anti-inflammatory medications, painkillers, without any regard as to their health. So painkillers like ibuprofen, brufen, diclofenac, aceclofenac, a lot of these, I'm sorry to mention the brands, but for the Kenyans who are here, taking Relief MR and Zulu MR, these are medications that should be taken once in a while for specific things. And many people actually abuse the use of these medications, and it is harmful to their kidneys. And we've had a lot of people actually coming in because of this. But at the same time, there is a cohort or group of people advocating for the use of herbal supplements or herbal medications for the treatment of kidney disease. And off the top of my head, as I was saying, I can think about 3 of my patients right now. One who unfortunately walked into my clinic in end-stage kidney disease, and I had no solutions for him. And because I had no solutions, he was like, I know a herbal guy who's promised to cure me. And another patient who went in for religious treatment, and he was on dialysis and refused to have any more dialysis after that, and unfortunately ended up passing away. Mm-hmm. So it really is very painful to us. And I do believe it's because patients don't really understand what's happening to them. And sometimes if we don't screen and patients come in too late, then we have no solutions to offer them except dialysis. And a lot of people get into a lot of despair. And the people who are offering herbal treatments or prayers are offering cure for them when really there's no cure, and they're in a desperate situation. So we are in trouble in that regard. But I would like to encourage people to talk to their doctors and talk to their nurses. I mean, somebody like Tabitha is a renal champion. If doctors seem unapproachable, but come and look for us, have a conversation, try and understand what's happening. We don't know what's in those herbal supplements. Actually, in the outbreak that we had that many years ago, we actually had, when we went to analyze what was been given to these individuals, it was crushed up NSAIDs that had been put into a green solution that was said to be herbal, and it was really damaging to the organs. So these are unregulated. Nobody knows what's in them. They're not cheap. They're expensive medications, but they prey on people's emotions, and they prey on people's people in difficult situations. And we've had many difficult outcomes because of that. Yeah.
Yeah, you just confirmed what I've always said about those herbal supplements. I see a lot of them under the disguise of Ayurveda medicine coming out of India. Yep. And nobody knows where these products been manufactured. And a lot of those have metals in it that can further damage the kidney. They have.
I'll do you one further, Steve. There was actually an expose that you can actually go on Alibaba or Amazon and buy the packaging. So buy the packaging for that, whatever that Ayurvedic thing is. And it comes in the capsule, it comes in the blister pack, it even comes with already written whatever is in it, and you can put whatever you want into that capsule. So the capsule comes empty, you put whatever powder, whatever you want in it, and you market it as that. Nobody knows what's in it. If you took 3 of them from the counter and sold them, and they're all under supplements, so they don't pass through the Pharmacy and Poisons Board, nobody verifies what's in them. And this is not just in Kenya. This is all over the world. In the US, there was an expose on these drugstore supplements. All of them are different. When you go in and look at what medicine is actually in that capsule, all of them are different. Nobody knows what's in them.
See, y'all hear that? Y'all hear it straight from the doctor's mouth. One more thing before I pass it to Moses. I was just talking about NSAIDs the night before last. And the reason why, Dr. Soki, because on social media, I saw a gentleman posting a video kind of promoting Tylenol with naproxen. How can you explain how dangerous that can be for patients with kidney disease?
Recently in Kenya, there was a comedian who did a skit, and comedy is actually a reflection. Moses and Tabitha will know. Comedy is actually a reflection of what is happening in society. And she did a skit, and the skit was talking about how Kenyans will use ibuprofen for everything. Anything, go take your brufen. Anything, go take your brufen or your diclofenac. These medications make you feel good in terms of joint pains. That is true. In terms of arthritic pain, that is true. But what these medications actually do to the kidney is that they cause a narrowing of the blood supply going into the kidney. And so in the long term, they cut down the blood supply of the kidney towards the kidney, and they actually reduce the blood supply to the filters of the kidney, so that in the long term, the filters of the kidneys are not getting enough oxygen. So we find that there are people, for example, I had a gentleman who was on these medications daily, twice a day for 3 months for gout. And he just came in with kidneys that had failed, and that was that. And at the same time, some people can get an allergic reaction to these medications called a tubulointerstitial nephritis, and this causes them to go into kidney damage. So these medications are not to be taken lightly. They are not to be taken for a long period of time. They are not to be taken without prescription. These medications are diclofenac, aceclofenac, ibuprofen, naproxen, meloxicam, piroxicam. I think in the age of AI, sometimes I encourage my patients, before you take any medication, just take a picture of it, upload it, and ask, is there an NSAID in this medication? Can this medication be harmful to the kidneys? And because in Kenya, we do get medications without a prescription over the counter. And I mean, NSAIDs are not prescription medications, even in the US and in Canada. So anybody can go and buy their naproxen, their Advil, and take it without any regard to their health. So it's important for people to know that these medications are not good for your kidney.
Wow. Thank you for sharing that. Really appreciate that. Brother Moses.
Thank you so much, Dr. I honestly agree with you on that part of herbal, simply because every product comes with a herbal version of it. Sometimes they go to that much extent, having things like even a shoe polish herbal. You wonder, you see the extent at which now, yes, including toothpaste and whatnot. So you get to wonder, why do we really need to have even a shoe herbal polish, honestly? Now, let me just add more one query.
And Moses, can I just say one thing?
Yes.
People are worried that our medications are chemicals because they are manufactured in a lab with standards. And that means every medication is something that and you know what it is going to do. It has been tested, and the outcome is known. It is reproducible. What I want people to know is that most of our medications come from nature. People think that our medications came from some chemical that was manufactured somewhere. Most of our medications come from nature. They come from plants. They come from tree bark. For example, one of the medications that we prescribe for all patients with kidney disease these days, called empagliflozin or dapagliflozin, these are called SGLT2 inhibitors, was discovered from the bark of an apple tree. It is just that if you were to go and chew the bark of the apple tree, we don't know which apple tree has more of the medicine than the other, and it also has other side effects. You see? So we go and take the part that is helpful, and we make it in a lab, and we give you the part that is helpful. What people need to know is most medications came from nature. They came from plants, they came from animals, they came from things that we already knew, and now we remove the side effects, majority of it, and we took the molecule that can help us, right? So nobody needs to sit here and think, I think that is the feeling from most people, and that's the thing that most people need to know. Yeah.
Wow.
Thank you so much. Okay. which people or group are at a risk and should be screened more regularly for kidney disease?
That's an excellent question. Thank you for that. So, number one, as we talked about, anybody with high blood pressure. So if you've ever been diagnosed with high blood pressure, then we need to get a screening for kidney disease at least once a year, preferably twice a year. Okay. And we're not just looking for what is your kidney function now, we are looking for the rate at which the kidney function is falling. Okay. The second is people who have diabetes. Anybody who has diabetes needs to get their kidney function checked twice a year at least. Anybody above the age of 65 years needs to get their kidney function checked. Anybody who has a history of kidney disease in their family, if you have ever had a relative on dialysis, or you have ever had a relative who has been diagnosed with chronic kidney disease, then these people need to get their kidney function checked at least once a year, preferably twice a year. If you were born premature, it's a good idea to get your kidneys checked when you're younger rather than when you're older, because people who were born premature didn't get enough time for their kidneys to grow and give them enough filters as compared to other people in the general population. And in your life, if you have ever had a major illness that gave you acute kidney injury, so you'll find sometimes people had a road traffic accident, or they had a major infection or a major surgery or blood loss that gave them, or sometimes women who had preeclampsia or hypertension in pregnancy. These are people who are at risk, because what happened during that time is that we ate up a significant number of filters within your kidneys, got damaged. So it's a good idea for us at least once a year to keep on checking on the kidney function and make sure that it is normal, or that it is not dropping at a faster than normal rate. And I would say anybody who is known to have a connective tissue disease or a disease that could affect kidney function. So for example, people who have autoimmune diseases like lupus or other connective tissue diseases, people who have gout, people who have HIV or hepatitis B or hepatitis C, and people who have sickle cell disease, or people who are even known to be sickle cell carriers, even when they do not have the disease. We find that these people tend to lose kidney function faster than the general population, and we should keep an eye on them. Tabitha, I don't know if you have other people that I have forgotten on this list.
I think you've mentioned most of them. Yeah, and even as you are talking, I was just remembering the way we've had patients come with acute kidney injury, post-abortal, using herbal medication. We also have ladies who prefer to use herbal family planning, where they swallow only one tablet, and then don't know the effect of that drug. We have men who have got enlarged prostate. We go for herbal. Instead of now the prostate reducing, what happens is that we move to either AKI or CKD, because the prostate keep enlarging, and with time we even dialyze them. So people need to be aware of that herbal medication, as we say, miti ni dawa in our Swahili language. Let people know that miti si dawa peke yake. Miti inaweza kuharibu figo. And just to ask you, Dr. Soki, in our community, many people get tested when they are already very sick. What test should people ask for before that happens?
So when we are encouraging people, thank you. When we're encouraging people to do this screening for kidney disease is an easily available test, available everywhere in our country. The test is called a creatinine test. So a creatinine test is a blood test, and the creatinine test costs by itself. You don't need to do a full kidney panel, but the creatinine test itself costs between 300 to 500 shillings. And using that test, we are able to calculate a percentage kidney function. It's called GFR, glomerular filtration rate. So by simply going to ask for a creatinine test, we are able to see where we stand. That is number one, but that is not complete. So before the creatinine test becomes deranged, so for creatinine, the lower the creatinine in your blood, the better for you. To give you a ballpark figure, if creatinine starts going above 100, we have a problem. Okay, that's just something to keep in mind. But before the creatinine starts to go up to show us that we have a problem in the blood, the first test for many people to detect that we have a problem is the urine. The urine test is a microscope into the kidney. So there are two things that you should never see in urine. Number one, you should never see blood. Number two, you should never see protein. So the urine test is a simple test available everywhere. Even in a dispensary, you will get a urine test. And that urine test is about 100 to 150 shillings, maybe 200 shillings. So never do a creatinine test without doing a urine test. And if the urine test shows blood, it's not blood that you see with your eyes. On the test, you will see it is saying blood trace or blood plus or 2+ or 3+. This is a kidney disease. If you ever see your urine test showing protein, this is a kidney disease. And this is showing that the filter is removing things from the body that should not be there. So why are they in urine? So if you see blood or protein in your urine, many times I get people coming into my clinic and telling me, I was treated for urinary tract infection for many years. That is not a urinary tract infection. That is a kidney disease. So when you keep on being treated for urinary tract infection, number one, make sure you see a kidney doctor or a physician and ask if you have a kidney disease, because before the creatinine becomes bad, the urine will usually show it.
Okay.
So those are my two tests for screening, creatinine and urine analysis.
Thank you so much. And people just need to be aware of that. And especially when they're pregnant, when they go for their for their test, or when they go to be seen when they are pregnant, they check on the blood pressure and they also check on the urine. I remember that time when we were pregnant, and some women are like, they're asking for urine. By the way, you can give me a little so that they can test. Only that somebody doesn't know that simple test is able to give us a lot. So pregnant women, don't make mistake. Yeah, don't make that mistake. I'd like to hand it over to Brother Steve.
All right, thanks, Tabitha. Dr. Soki, we know that I'm sure healthcare is a big issue in Kenya and East Africa. What would you say to the average person that is walking around with undiagnosed hypertension, undiagnosed diabetes, may have a family history of kidney disease and don't know? How would they start to get routine kidney checks if they can't afford the test?
Yeah, that is difficult. I think it's about having a high index of suspicion and knowing when you are at risk. It's not something to ignore. Many people think that these are expensive medications, and many of them are. But the most basic of medications is actually quite affordable. It doesn't take us going to Kenyatta National Hospital. It does not take us going to Nairobi Hospital. We need to empower ourselves. We need to learn. I can tell you that our first line medication for kidney disease is something called enalapril. I think you can get a full month's dose of enalapril at your county hospital, your dispensary, your health center. Tabitha, tell me if I'm wrong, for less than 300 shillings. There is a medication all around the country which is available called losartan. Even Moses will tell you, Moses knows losartan because it is available everywhere. And this medication is not expensive. This is our first line medication that protects against kidney disease. So when you have chronic kidney disease, this is the thing that is prescribed for you. Our second line medication, which is the SGLT2 inhibitor, is more expensive. That is true. But these medications, through generics, Kenya has actually been flagged as one of the countries in the world, if not the first in the world, in the use of SGLT2 inhibitors, because we have many generics that are available. Some of them are even made in Kenya. So for less than 1,000 shillings a month these days, you can get an SGLT2 inhibitor for the whole month. But the major ways to reduce kidney disease for most people are simple ways. It is not a complicated thing. Number one, control your blood pressure. If you have high blood pressure, ignoring it is not going to make it go away, even if you feel well. Whenever your blood pressure is above 130, this is going and, to put it simply, bursting the filters of the kidney. This is going in and blocking the filters of the kidney because the blood pressure is too high for the filters of the kidney. The simplest thing that you can do to preserve your kidney function is to control your blood pressure. A full month's dose of nifedipine is less than 300 shillings. A full month, it's made in Kenya. A full month dose of hydralazine is less than 300 shillings. To give you context, Steve, 300 shillings is $2 for a whole month supply.
Wow.
A creatinine test is $2. A urine analysis is $1.50. So it is up to us to change our health care, our health.
Pay that over here.
No, there's no such medication in America.
Yeah, I know.
in Kenya,
I know.
in Kenya. So
That's
it is up to us. Yes, it is up to us to prioritize our health. Many people have been told they have high blood pressure, but they feel fine. So they ignore it for many years, and by the time they come in, it's too late. Don't ignore your blood pressure. Don't ignore your blood sugar. There are access programs for availability to insulin. A full dose of metformin in Kenya is less than $3, is less than 500 shillings in Kenya. And metformin is the first line medication for blood sugar. So it is up to us to take care of our health, because in diabetes and in high blood pressure, not only are you saving your kidneys, you are saving your brain from stroke. You are saving your heart from heart attacks and heart failure. You are saving your feet from being amputated. These things are key. When you realize it, saving our health is the best thing that we can have. So saving our health gives us the freedom to work, the freedom to take care of our families, the freedom to continue having good times with our families, which is the thing that is important. So ignoring high blood pressure is not going to help. It is not going to go away. Ignoring high blood sugar is not going to make it go away. It is time for us to do something. And prioritizing $10 or prioritizing 1,000 shillings for your own health is important, because at the end of the day, if we have lost kidneys, we have lost heart, we have had a stroke, we don't have a leg, finally it's going to interfere with our ability to take care of our families and to interact with our families. So even when you feel like you don't have that money, prioritize your health first.
Mm-hmm. Doc, before I turn it back over to Tabitha, we had a question in the comments from P-Teach 9957. Says, can the doc speak on a whole food or plant-based focus for a renal patient? Now, before you answer that, we know, well, I'm gonna say we, but I know most doctors don't get no extensive nutritional training and in medical school, and you're not a dietitian.
No.
But from the best of your knowledge as a practicing nephrologist, I mean, is there anything that you could speak on? Meaning, is that something with someone dealing with kidney disease, not on dialysis, but maybe on dialysis? Could that just be a beneficial part of someone's diet and practicing plant-based diet?
So this is a regular question that comes up, and thank you, Steve, because I am not a nutritionist, and as doctors, as you say, we do not have extensive nutritional training. What I will comment is this, because we need to interpret the information that we read online very carefully as Kenyans. So right now, we are getting increasing evidence to show that a plant-based protein is actually better for your kidney health all around. That people who are on plant-based proteins and whole foods, there is an unhealthy plant-based protein, an unhealthy vegetarian diet. People can have deep fried foods and fatty foods even when on a vegetarian diet. So this whole food plant-based diet for patients who have chronic kidney disease is something that we are actually recommending, because this gives us more alkaline than animal proteins, and this has been found to be protective over kidneys. Now, caveat. Number one, this is for people who have chronic kidney disease and are not on dialysis. And even for those who have chronic kidney disease, remember that plant-based diets are high in potassium, and plants are incomplete proteins, which means they make more urea. So a plant-based diet is not for everybody, even when they have chronic kidney disease. So it's something to talk to your doctor about very seriously, and it's something to talk to a nutritionist or dietitian about. For patients who are on dialysis, remember that plant-based diets have more potassium usually, because plants are high in potassium on the whole. And in a Kenyan context, most of our patients are only on 2 times a week dialysis, and so we struggle with high potassium. So I cannot encourage anybody to go on a fully plant-based diet when they are on 2 times a week dialysis. I really can't do that because of the risks of high potassium. So this is really something, So this is something to be taken up with your nephrologist and have an individual conversation about it. And this is something to be taken up with a nutritionist or a dietitian personally, because again, for those people who have chronic kidney disease, what stage of chronic kidney disease is it? Is it stage 4? Is it stage 3B, 3A, or stage 2? And depending on what stage you are at and how much kidney function we have, we will recommend something different. And secondly, even on dialysis, there are those patients who have a normal urine output. So I have many patients on dialysis who have a normal urine output. These people have a completely different diet or different dietary recommendations as compared to people who do not have any urine, or people who are on 3 times a week dialysis, or people who are on peritoneal dialysis, because we also have patients who are on peritoneal dialysis who we encourage to have a high potassium diet. So do reach out to your nephrologist, do reach out to your nutritionist or dietitian, and they would be able to give better advice.
Yeah, thank you for answering that question. All right, Tabitha, it's on you.
Thank you so much, Dr. Soki, for that. And I would request, if you are there on dialysis and you've never met a nutritionist, you can ask Dr. Soki. You can also ask Moses or even myself. We can recommend you to see any of the dietitians that we know who are going to take you through the diet, either for dialysis, or maybe if you are management again, you can also be assisted again by the dietitian. Thank you so much. If a patient is told that there is protein in urine or the kidney function are worsening, what is the next step for that patient? Yeah, what is the next?
I'm assuming that question is for me. So if there's protein in your urine, as we said, that is an indication that we have a problem with the filters of the kidney. And if the kidney function is deteriorating, then we know that that is not a good sign. So it depends. You need to find a kidney doctor. Usually we have a criteria where we advise you see a kidney doctor. For example, if you have protein in your urine more than 300 milligrams in a day, sometimes more than anywhere above 100 is usually a good sign that you need to go and see a kidney doctor. And if you have, and to be honest, by the time you're doing a urine dipstick, that means we have more than 300 milligrams of protein in the urine, and you should see a kidney doctor. The second thing is that if kidney function is falling, then we need to see a kidney doctor. Actually, you are one of the patients who has been caught early, and we must try and treat the underlying disease. Now, there are many diseases that can cause kidney disease. As we've talked about, one is diabetes, one is high blood pressure, but we also have inflammatory diseases of the kidney. They're called glomerulonephritis, but it just means that the filters in the kidney are inflamed, and so they are letting out things that they should not let out. There are many diseases like that. Some of them have very simple treatments like steroids. Others have very simple treatments like a drug called tacrolimus, just 1 tablet or 2 tablets in a day, and we find that you get treatment. So it is important for us to make a diagnosis, and it is important for us to get treatment before kidney function falls, and we can actually save those kidneys. So anybody who has falling kidney function or protein in their urine needs to see a kidney doctor. Just Google any kidney doctor in Kenya, go to the one that is nearest to you and have a conversation with them. There are kidney doctors in the county hospitals in major cities. We have kidney doctors in Coast, kidney doctors in Kisumu, in Eldoret, in Naivasha, in Nakuru, in Makueni, and in Meru. This is where you will find kidney doctors, and of course in Nairobi, at every county hospital. Just go there and insist on seeing a kidney doctor.
Wow.
Wow. Thank you so much.
Brother Moses, before you continue, I just wanted to say, Doc, back in 2002, I was spilling 3 grams of protein in my urine. I had an unknown viral infection come through and kind of mess with my body a little bit. Needless to say, everything is well. I do have stage 2 kidney disease as we speak. However, you know, my age, I'm 62, and my kidney function right now is at 83% as far as GFR. But with that being said, can other conditions like viral conditions come through and affect someone's kidney function for a period of time that may cause maybe some type of acute kidney injury, but they may not? So when that happened to me, my BUN and creatinine still stayed normal. I didn't have any swelling in my legs or any of that. So could that happen to a person that could have this much protein spillage and not exhibit any symptoms of that situation?
Yes, in fact, you are our advocate. You are one of the people that we talked about should continue to get their screening, and you have done that. Thank you very much. You're one of the people who, you know, we get treatment, we get supportive care, and this happens a lot. So for example, we saw it a lot during COVID. One of the signs of COVID, the way that COVID affected the kidney is that it caused inflammation within the filters of the kidney. And a lot of people spilled out a lot of protein and a lot of blood in their urine, which they shouldn't have been doing. And it was because of the viral infection that they had. For a lot of people got a bit of kidney injury, and we saw the creatinines going up a little bit. We actually have a paper out on that. That was published, and we saw a little bit of an increase in the creatinine, but for most of them, they just recovered. A lot of them just actually needed support. We had a few patients that got something called a collapsing glomerulopathy, which means that their filters were significantly affected by COVID. They were a minority. Most people just spilled out some protein and spilled out some blood, and then as the COVID recovered, they recovered their kidney function, and they didn't even need any intervention from us at all. Some people got this collapsing glomerulopathy and they needed support from us. We follow some of them up until today. I have 2 patients that I follow up from COVID in that way. And they're doing okay. After they recovered from the COVID, we were able to support and we were able to maintain their kidney function. So both of them have about 20% kidney function for the last 5 years, but we're following them up and they're fine.
Oh, that's
sorry?
5 years at 20%?
5 years. Yes, because they had nothing else. So we just give them the medications to support their kidney. They developed high blood pressure. Both of them developed high blood pressure because of this. And both of them were a lady and a gentleman in their 60s, now in their 70s for both of them. So it was an interesting thing that we were seeing. We support them. We continue on medications. They're perfectly fine. They're not on dialysis. So we see that actually after viral infections, we see that after bacterial infections, there's something called post-streptococcal glomerulonephritis that we see especially in younger people. They get a bacterial infection, a throat infection, sometimes it's a viral infection, sometimes they get a bit of food poisoning, then you find your kidney reacting to that. We support them through it, they recover fully. Sometimes we find people who have something called
strep throat.
Yeah, there we go. Yes. And sometimes strep throat results in a kidney disease. And then sometimes we get people who have something called HUS. And this happens especially in younger people. In older people, is something called TTP. And it's a situation where you get a bacterial infection and then your body mistakes the bacteria for your own self. And so you start attacking yourself. For many times, for some of these people, especially in the children, we don't actually have a treatment. But what happens is that if we did not support the children through it, the children might end up dying. When actually, if you support the children through it, some even end up on dialysis for a little bit, but then they recover their renal function. So if you did not intervene and support them and keep them alive, after sometimes their kidney function just recovers. So it's of importance to go in, get a diagnosis, and then for many people, they actually just recover. But we keep tabs on them and we keep them very close to us and we watch them for the rest of their lives. Yeah.
Wow.
Yeah.
Wow. All right, Brother Moses.
Well, Daktari,
yes.
For someone who has just received abnormal kidney test results, what should they do right away and should they not avoid?
I would say an abnormal kidney function test is an indication that you should go and talk to a kidney doctor, because you have to find out where you are. You have to find out what got you there. So what is the cause of this kidney disease? You must start the medications on it, if there's any medication. Sometimes, for example, I would say Steve probably is not on any medication, because his kidney function is quite stable where it is. He doesn't need anything, but we just keep an eye. So what caused it? At what level are you? Do you need any medication? And does your kidney need any support? So for example, you'll find people who have less than 25% kidney function. There's medications that we start them on to support their kidney, not even to treat the kidney disease, but to support the kidney function so that they feel okay, they're normal, they don't have to, what changes in diet do we have to make? So for many people, actually, when they get abnormal kidney results, these are people who we see in our clinics, we advise them. And then for many of them, we see them after 6 months or 1 year, we reassure them, we say, this one is being caused by your high blood pressure, just control your high blood pressure, you're okay. Many people above the age of 65 to 70 years have kidney disease because of cholesterol. It's normal for them. We tell them, okay, we'll just control your cholesterol, do this, protect your kidney, don't take any painkillers, make sure you hydrate well, don't get dehydrated. We give them their vaccines so that they don't get sick, they don't get influenza, they don't get pneumonia. We keep them healthy. And then we tell them, okay, we'll see you in 6 months. These people, we just follow them up, But there are people who they walk into our clinic, they have 23% kidney function, they have active protein and blood going on in their kidneys, and we tell them, okay, I'm going to be seeing you every week or after every 2 weeks. We're going to figure this out very quickly. We're going to stop the damage now, and then we're going to make a plan. for the future so that we try and avoid this kidney function falling. These are two very different people. But for either one of them, we want to have a look at them first. As kidney doctors, we are very few kidney doctors in the country, as you are well aware. We have worked on it a lot over the last few years. So I think we're about 55 kidney specialists right now in the country. But that is 55 kidney specialists for a population of 55 million. So what we usually do is be assured that we are overwhelmed by work. We want to see our patients, we give advice, and then usually we refer our patients to the nearest physician. So for example, I have patients from Naivasha, I have patients from Kerugoya, I have patients from Nanyuki, I have patients from Tamburu. These patients come in, I give instructions, I send them back to their physician. This, I will see you in 3 months. These are the instructions, when to come back, what to do. And we work with your local physician to make sure that you're well taken care of.
Wow.
Yeah.
Back to you, Steve.
Dr. Soki, you talked about diabetes and hypertension, and here in the United States, they're the two leading causes of kidney failure, and I'm sure in Kenya as well. But for the average person, in Kenya or East Africa that may have undiagnosed diabetes, undiagnosed hypertension, or even they know they have it, can you just explain to them or people watching that's dealing with this in simple terms how diabetes and high blood pressure silently damage the kidneys over time?
Okay. I love that question. I think I have been accused, by the way, of trying to simplify things too much, but if you want me to get more complex, I can. So I'm going to try.
To where someone can really understand that has no medical knowledge.
Yes, let's do that. So I want everybody to know that we have two kidneys. They're at the back over here. That's your flanks. Each kidney has about 1.5 million filters. So on average, in a human being's body, we have around 3 million filters, 1.5 million, 1.5 million. And each of these filters works by itself to filter out the waste from the body. Now, the blood that is entering the kidney has waste. This waste, for example, we'll say one of the ones that we know that we use to measure kidney function is creatinine. So the creatinine enters the filter, it is filtered out comes urine with the creatinine. Now, what diabetes does is that diabetes is a disease. So these filters are very, very small. And the filters are made up of blood vessels. It's a little tuft of blood vessels like this. And diabetes is a disease of blood vessels. So most people who have diabetes don't realize that diabetes is a disease of blood vessels. They say sugar disease. Yes, but what does the sugar do? The sugar eats away at the blood vessels. The sugar, whenever sugar is above 8, I will say, normal sugar should never go above 7.8. So for me, whenever sugar goes above 8, it is just eating at the blood vessel and eating at the blood vessel. And what it does to the blood vessels in the kidney, because the blood vessels of the kidney are so small. Remember, there are 1.5 million filters. They're made up of tiny, tiny blood vessels. So when something is eating away at those blood vessels, it causes the blood vessels to get damaged, to burst, and to block. So one by one, you had very many filters. Remember, 80% of your filters were spare. But now, one by one, the filters, because of the blood entering, having too much sugar, the filter gets damaged. And once the filter is damaged, I usually give my patients the example of your eyes. Your eyes are highly specialized. There's no other place in your body from which you can see. Only your eyes can allow you to see. But many people would have seen somebody who was hit in the eye with something, by a stone or something, got trauma to the eye. And when that eye heals, it heals white. It heals with a scar. And the scar cannot see. Kidney filters are like that. There is no other place in your body that you can make urine. So those kidney filters, once they get hurt, once they get damaged, they heal with a scar. And after that, they cannot filter. So what happens in diabetes? One by one, those filters get spoiled and they heal with a scar. Then they are gone. Spoiled, heal with a scar, and they are gone. And just like that, we start losing filters from 3 million to 2 million to 1 million until we are left with no filters. That is what happens in diabetes. Similar thing in high blood pressure. A normal blood pressure is supposed to be 120/70. When pressure enters those very small blood vessels at a high rate, 140, 150, 160, 200, 220. Somebody right now I can see has just sent me a message on WhatsApp that his blood pressure is 220. I will deal with that after this is over. But when blood pressure is that high, it goes into those very small blood vessels of the kidney and it just bursts them. So one by one, we just lose filter. Once the filter is burst, it can no longer filter. So the kidney is not able to do its job. It is very few kidneys that actually lose their function over 1 day or 1 week or 2 weeks or a month. For most people, we are losing 1 filter per day, 1 filter per day, 3 filters per day, and we're just losing them like that. So that if we stop the damage, then we are left with a good number of filters. So people who have diabetes and high blood pressure, every time your sugar is above 8, every time your blood pressure is above 140, we're just losing filters. And then you go and add on diclofenac, and we're just losing filters. And then you get dehydrated, and we're just losing filters. And then you get influenza, and so this is what happens to people over time. So that is why I was saying that ignoring the problem will not make it go away. In fact, it is making the problem worse. This is how diabetes and high blood pressure affect the kidneys. And for many people who have diabetes, they also have high blood pressure. So diabetes has already weakened the blood vessel and blood pressure comes to finish it off. And this is how we end up in kidney disease. Does that make sense? Is that okay?
Oh, yeah, it makes perfect sense. You explained that very well. But just one thing I wanted to ask you, you mentioned that you got a text from a patient for hypertension. Yeah. So over in Kenya, patients have access to you like that? Because here in the United States, many of the nephrologists are not going to get a number out to their patients because they have a high census. They may answering service or whatever, but they wouldn't take no call. Just somebody's pressure is high. They were like, "Why are you calling me? Go to the emergency room." But I'm sure the culture is different there. But your patients have access to you like that?
So the person who just sent me a message is my relative. But
okay.
To be honest, many of our patients do have access to us. It can get overwhelming sometimes. And the usual correct answer is, so we will not respond on WhatsApp or will not respond on message because it's very difficult to respond to a patient that you cannot see. And my first response to most patients will be, which is what I have just responded, is you need to get to a hospital immediately because I cannot see you. Are we having a heart attack? Are we having a kidney issue? Are we having difficulty in breathing, which can happen when blood pressures are that high? It is a bad idea for you to stay home when your blood pressures are that high. So the first thing to do, if you're not feeling well, go to any emergency department so that we can see what is going on with you and we can help you. Usually that is my response. Many times patients will call you and they just tell you the most horrendous thing. They will call you at 4 o'clock in the morning and say, you know what? My heart rate is 160. What do you think I should do? You should go to the hospital immediately. And many patients actually will sit at home waiting to sit and see what happens. Don't sit and see what happens. Go to the hospital immediately, even if it's to be told that you're perfectly fine and your machine was faulty. Go to the hospital immediately. Don't sit at home waiting. I had a patient call the office the other day and say she's coming into the office because her heart rate is 30. No, do not go to the doctor's office when your heart rate is 30. You need to go to the emergency room immediately. So many patients actually, and this even happened to a patient who was a very high profile patient, which everybody will know, where he was sitting at home feeling very unwell, and he called his friend who was a doctor to come home and see him. By that point, when the friend came, they were resuscitating him at home. The thing to do if you're not feeling well, go to the hospital. Don't wait to talk to your doctor. Don't wait for your doctor to respond to your message. Don't wait for, just go to the hospital. Even if it's the dispensary near you, even if it is the outpatient facility near you, go to the emergency room. That is the right thing to do.
Yes, that's what we say here. Call 911.
We don't have 911. That is the problem. We don't have 999. Look at Moses just laughing there. We don't have that. But for many patients, they will get an Uber.
Right. No,
which might be faster than getting an ambulance and try and make it to the hospital.
Right.
Yeah.
All right, Brother Moses.
Well, we are also running out of time.
Yeah.
Maybe I'm going to invite Steve to conclude. We are almost past time.
Okay. Doctor,
so I'm going to be conscious.
You press for time, Dr. Soki?
I think I just need to deal with this blood pressure of 220.
Oh, okay. Oh, absolutely. Well, okay. I completely understand that work is more important. Most definitely. Well, let me just say we're honored to have you come on, and we would like to bring you back if you can at a future date to continue this discussion and even other discussions centered around transplant, prevention and diagnosis of kidney disease. Any last parting words you would like to say before you leave the broadcast?
I think I would like to say, I would like to remind everybody that kidney disease is not something that is limited by age. A lot of people feel like they can't have kidney disease because they're too young. Kidney disease is found in children. Actually, for many people, kidney disease starts in childhood or in their early teenage years or adolescent. And that's why we should do a urinalysis for children also, and we should do blood pressures for all children. So if children do end up in a doctor's office, an emergency room, I would insist that my child needs to get a blood pressure check. And that's how we diagnose many kidney diseases early. So it's just to remind ourselves that kidney disease is not limited by age, and we need to be aware that 50% of the patients in our dialysis units are below the age of 40 years.
Wow. Dr. Soki, thank you so much for joining us and for sharing your knowledge and experience with our audience. We really, really appreciate you taking the time out of your busy schedule.
I'm so honored to be here. I'm just so happy to have the opportunity to meet other advocates, just encouraging people to get themselves checked out for kidney disease. And Moses, just an absolute champion. Tabitha and Steve, thank you for taking your time to do this very important and vital work.
All right. Thank you, Dr. Soki, for coming on, and have a great evening.
Thank you. Thank you so much.
All right. Take care.
Bye-bye.
All right. Brother Moses, Tabitha, what are your thoughts on this important conversation we had with Dr. Soki pertaining to early detection for preventing kidney disease? We start with you, Tabitha.
So lovely, so powerful. Hearing from a specialist, it is such a great insight, even for many patients and even to the community. It's a powerful conversation, Brother Steve. Yeah.
Okay. How about you, Moses?
Definitely. I must echo my sister Tabitha that it is absolutely a good thing to have a specialist here. I also have one suggestion also that I know, Tabitha, we are going to give you space so that you can also have your time as as our guest in your show,
Okay.
so that you also get time to share with us something that you so feel. So maybe I know Steve can think about it. You too, you can, and we can forge something together. So
Wait a
that
minute, I'm sorry, Moses. I missed that. What was you saying?
I was saying, first of all, I want to echo Tabitha's words that it was a great show. Indeed, it was, for having Dr. Soki to be our guest. So in that same breath, I will request that if we can plan forward, if Tabitha agrees, or you also agrees, because this is just still a suggestion, because we work as a team. You, Tabitha, I will request that we spare also one day or one of these Sundays. We'll schedule that so that you have your time, and also pick on a topic and share with us. What do you say, Brother Steve and
Oh, you
Sister
talking about
Tabitha?
with Dr. Soki?
Sorry?
Are you mean with Dr. Soki, or you just talking about in general?
No, I'm okay. Alongside other professionals,
Mm-hmm.
I also would wish to schedule Tabitha as the guest. Let me put it that way, so that he also
Having Tabitha bring a guest on.
as the guest, so that she can also expound on numerous issues that she.
No, I got what you're saying.
All
I
right, all
completely
right.
understand, and
Yeah.
I'm definitely open to that, Tabitha. I'm sure you have a network of people that you can reach out to, and that's what I'm more than we more, because we, like Moses says, we now work as a team. It's not just me and Moses anymore. It's you, Moses, and I. And so if you have any guests that you would like to bring on, and a topic that you would like to discuss, please let one of us know as soon as possible, so we can work on the show production. So yes, I'm very, very open to that, Brother Moses.
Yeah. So in conjunction to that, I can slot maybe one of these Sundays, and now we invite Tabitha as the guest. Yeah, something like that.
Okay.
Yeah.
So, Tabitha,
So
anything?
on that day, she
Oh,
will
go ahead,
not
Moses.
be. On that day, she will not be a co-host, but will be purely a guest. You got it?
Oh, got you.
Yes,
I
that
got
is
you
what I'm
now. I
explaining.
got you now.
Yeah,
Okay.
yeah.
Okay. I
Yeah.
mean, I'm open to anything that's
Okay.
going to get the information out
Okay.
there to people who need to hear, especially in East Africa. On
Mm-hmm.
Tabitha, I mean, just from a professional standpoint, and you knowing Dr. Soki, and I'm sure this is probably the first time you've been on a broadcast with Dr. Soki, And I'm sure that in Kenya, maybe where you work, I'm not there. That may be a big deal because I'm not there in that environment in your reality. And so I'm sure Dr. Soki is a well-known nephrologist there in Kenya. And by this being the first time that you shared this platform on social media with Dr. Soki, I'm sure that's no small thing in Kenya because of the status of kidney doctors and how kidney patients may look upon them for their care. What did you get out of this broadcast today, and how important is it to have these type of broadcasts with professionals like Dr. Soki, given the state of kidney disease in Kenya?
I think it really builds a lot of confidence even in the show, because when people hear such a renowned doctor, because he works in one of the largest private hospital in Kenya, where people like even our president would visit and be treated. He would be the nephrologist there. If there is any member of parliament is sick, that is the hospital where they go, where Dr. Soki is one of the chief nephrologists there. You can imagine when people, when the community knows that you're doing a show with such kind of people will have even confidence in the show, and they will also want to listen to whatever we are saying, because now they've gotten the point that this is a very important show and there's a need for us to prevent the kidney disease before it can damage our bodies.
Mm-hmm. Mm-hmm.
Yeah.
Brother Moses, let me ask you before we conclude. We've been doing this about 4 or 5 years. I can't really
6.5 years.
Okay, I know you can always pinpoint it. Six and a half
years. Yes.
That's the longest that I've ever done a podcast show with someone consistently. But 6.5 years, being where you started from, when you first started using the name the Kidney Ambassador, and trying to get information out there to other patients such as yourself that's dealing with this disease. When you look at from where you began, and we done talked to maybe 1 or 2 kidney doctors throughout the years, not many, but being here today and looking at the accomplishments and the background and the impressive resume or curriculum vitae of Dr. Soki, what does that mean to you to be discussing early detection of kidney disease with a distinguished nephrologist in Kenya, such as Dr. Soki, on a platform where other people, will be watching? What does that mean to you as a kidney patient of, I believe, 7, 8, 9 years fighting this battle?
Number one, let me acknowledge, well, we've had 2 before. We've had Dr. Kell twice before on this same show, Kidney Hub East Africa. Now, working with the nephrologist who many a times they've got a busy schedule. If one would spare time or create time for purposely Kidney Hub East Africa, then there is satisfaction that a journey that once began with one step is headed somewhere. And more so, as a patient, I really get fulfillment when I can share and I can coordinate to other fellow kidney warriors to the point that they get nourished with the much needed correct information. You know, every information is out there, but other information are confusing. So if doctors come, renal specialist nurses like Tabitha come, then they debunk on so many misconceptions that surrounds kidney failure. Yeah.
Wow. Thank you for sharing that. I know we've been on for nearly going on 2 hours. I know it's in Kenya, it's going on 10 o'clock p.m. I know y'all had things to do, but I just want to thank both of you, my co-hosts, Moses Kennedy, aka the Kidney Ambassador, and renal nurse specialist Tabitha Matikwa, for this excellent conversation, and again taking time out each week to share their wisdom and knowledge on our weekly discussion. So I won't hold both of you. Again, thank y'all for coming on, and we'll see you next week. And I'll just, close the show out from here. All right.
Thank you.
Anything you want to say, Tabitha, before we leave? Any last
thank
word?
you. Have a great week. The month of August has started. Have a great one. Yeah.
Yeah, absolutely. What about you, Brother Moses? I know you just
Bye-bye,
spoke,
everyone.
but any last parting words?
All the best. Have a great week.
Yeah. All right, we'll talk after the show. I'm going to go ahead and let y'all down, but have a great week, Tabitha, Brother Moses, and we'll definitely see you next week, okay?
And thank you so much.
All right. To everyone else, thank you to everyone who watched us live on Steve the Kidney Nurse YouTube channel, Steve the Kidney Nurse Facebook page, and the Figo Initiative Facebook page. Now, the Figo Initiative Facebook page is ran by Brother Moses, and that's our international page. So please go like, share the Figo Initiative Facebook page. Also, want to thank everyone for tuning in. And again, you can follow us and like, comment, and share at Steve the Kidney Nurse YouTube channel, Steve the Kidney Nurse Facebook page, and again, the Figo Initiative Facebook page for more kidney awareness, education, and survivor stories. And with that being said, please remember, early detection, I repeat, early detection saves kidneys and it saves lives. Until next time, everyone, stay informed, stay screened, and stay healthy. We see you next week. God bless and have a great week. This your boy, Steve the Kidney Nurse, and I'm out.